All right, everyone, welcome back. Today I have Heather Jeffcoat with me. She is an orthopedic and pelvic floor physical therapist. She has several Los Angeles locations. She is the owner of Femina Physical Therapy and is the current president of the Academy of Pelvic Health Physical Therapy, as well as serving on the advisory board for the International Pain Society. Holy crap, that was a mouthful. Heather, how did I do?
Almost perfect. The International Pelvic Pain Society,
Darn.
not just pain, although we do talk about pain in general. So like a lot of the pain research comes from not just pelvic pain. So it's all relevant. It's good.
Hilarious.
Yeah, I will say that even though I serve on these boards, like anything we chat about is my own opinion and not the view of any of the boards that I serve on.
Yes, of course, of course. And today I'm really excited. We're going to be talking about some overlapping chronic pain conditions. I really want to dive into the topics or the conditions of vulvodynia and vestibulodynia. I feel like those are conditions we haven't talked much about on this podcast before outside of my personal journey with them. So I'm really excited to dive into that. But can you give the listeners a little intro on who you are and how you got into being an orthopedic and pelvic floor physical therapist?
Absolutely. So my journey to becoming a physical therapist started when I was in undergrad. I didn't know what I wanted to do. So figured it out through a family member that had a stroke and thought, well, physical therapy seems kind of like in my lane. Did a bunch of volunteering as is required before you go to PT school because they want to make sure you understand the profession you're going into. So I went into PT school at Duke University thinking I want to do pediatric physical therapy. I'm so far from that right now. But what I kind of realized through my journey there was really I wanted to work with like athletes and young athletes. But then when I got into that setting, my very first job out of PT school, I was working with the exact population that I wanted to work with, doing sports medicine. And I just was really crushed by the way the particular company ran their patient care. And it was like, sometimes I would have 6 patients per hour. I mean, you're just not providing care at that point. You're just passing off to unlicensed people and you're writing all the notes at the end of the day. And there's no joy in that. So at the time, a friend of mine was working about 20 miles away. And this was in Raleigh, North Carolina. And they were looking for a pelvic health and an orthopedic therapist, and they were willing to train me and send me to courses. So at that point, I learned about pelvic health in PT school because Duke had actually a lot more information at the time than a lot of other PT schools had, but I just wasn't completely sure I was on board with that being my path. But I was like, well, okay, it's like 50-50. At least maybe I'll be doing what I like half the time if I don't like this pelvic health thing. And then it turns out like I totally loved it. Like it was so rewarding from day one. I had so much passion coming out of the first 3-day course that I took to get training and how to assess and treat basic pelvic floor conditions. And just like to see the progress in patients and you're helping them with something so intimate, getting them back to, running without peeing their pants, getting them back to intercourse with their partner, or even intercourse for the first time. I see a ton of unconsummated marriages, and it's just pretty incredible the impact that I was making in these women's lives. So I just kind of dove all in. I was like, I am all into this, and took more and more classes, and then kind of realized, I've taken all the classes and had to develop my own techniques, my sort of own order of operations for what I thought worked best with my patients over time. And eventually wrote the book because I was doing a little bit of media and people were reaching out to me for answers. And I'm just like, I can't provide answers over email. So that's kind of, after I had been practicing 10 years, I started to write the book. And then it took me about 2 years to write.
Wow. And I recently had Ingrid Harm Hernandez on, who also I think worked with Duke.
She's at Duke. Yeah, I've known her for a long time.
And then she wrote a book. So it's cool that you guys are doing this. And who's the target audience of the book?
It's for patients. Like, it is very patient friendly in language, digestible. It's 99 pages. When I set out to write the book, I honestly thought, I just want this to be just like the meat of the info. When people have painful sex, they don't want to read a 400-page book about how to help their painful sex. So I wanted to make it really like, I can do this. I'm not overwhelmed by trying to help myself. But I actually have a lot of physical therapists that use the book themselves and use my techniques to train their patients. So it's used by professionals. I have like psychotherapists that give it or recommend it to their patients. OBGYNs, but the ones that are like truly using it are, I think, the PTs and the patients.
Yeah, that's amazing. And can you review what types of conditions could contribute to pain with sex?
Absolutely. So there are many different conditions, some that would be appropriate for a physical therapist to treat, some that would not. So, it has to be medically cleared. If you have a new onset of painful sex, really the first person you should see is a physician. You need to make sure you don't have an infection, a cyst, or something medical that needs to be treated. I think after you see the doctor, if they say there's nothing wrong, that's kind of when people come to us, when they're told there's nothing wrong, even though there's, either some like nerve hypersensitivity at the vulvar opening, the opening of the vagina, the vulva, specifically, typically more the vulvar vestibule. There could be pelvic floor muscle overactivity that's creating their pain, and endometriosis, which, even though that is a surgical diagnosis and treatment for that, we can still help with the secondary effects of that, such as pelvic floor muscle overactivity, the bowel and bladder dysfunction that tends to happen concurrent to that condition as well, due to pelvic floor muscle overactivity. And we can help manage chronic pain. So when someone has any sort of chronic pain, there are changes in the brain that happen, and your brain essentially amplifies all the pain that you feel. And it's a process called central sensitization, if anyone wants to deep dive and Google into that. But it makes any pain you feel louder than someone else that may receive the same stimulus. And it can get so severe that even a non-painful stimulus, like for example, a Q-tip on your skin, usually the test is done at the vulvar vestibule, but even a Q-tip can cause pain, and a Q-tip should not cause pain, right? So that's just part of the nervous system that we can also help work on in combination with physicians that are helping to manage pain, whether they're traditional physicians or holistic physicians. I work with all kinds. I'm here in LA, so we have all types of providers that are geographically accessible to patients. So, those would be some of the main ones. Vaginismus, vulvodynia, endometriosis are the most common that I see here, and a lot of times they'll have interstitial cystitis or painful bladder syndrome, which many of those patients also have painful sex as well. They tend to have vulvodynia and or vaginismus.
Mm-hmm. Yeah, there's a big overlap with all of those. What is your treatments? Oh, go ahead. What were you going to say?
Oh, I was just going to say there's also a broader term that doctors will use called dyspareunia, which just means painful sex. It's kind of like saying low back pain. It's like okay, it's a symptom, even though it's listed in like the medical coding as a diagnosis, it's really just a symptom. It doesn't tell you why you have painful sex. Vaginismus tells you why you have painful sex. It's a muscle issue. Like vestibulodynia, painful vestibule is what that means, but it also at least tells you your pain is in your vestibule, even though they have to determine why that is, whether it's hormonal difficulty or hormonal challenges, maybe I should say, or nerve proliferation, like an overabundance of nerves in the area, they get hypersensitive. So yeah, dyspareunia is another word people may have heard, and I just wanted
to picked a better word for that.
It's a mouthful.
I feel like there's so many words for female pelvic pain conditions that are just like so difficult. Like interstitial cystitis, vestibulodynia, like they're all just a mouthful.
Yeah. And that's why, like with interstitial cystitis, the preferred term now is painful bladder syndrome or
It makes
bladder
more
pain
sense.
syndrome. Yes, because it is and it makes more sense, but even with them, it's not even necessarily a problem with the bladder. It's a problem typically with the musculoskeletal system and the nervous system and how they interact that creates bladder symptoms.
Mhm.
So that's why pelvic floor physical therapy and specifically manual therapy, like hands-on therapy, is one of the top tier recommendations for that before doing like other things that have been done historically, like installations and things like that.
Yeah, the more invasive treatments.
Right. That my
Mhm.
patients always say it made them worse. Like 98% of the time, my patients say those treatments flared them up so bad.
Right. No, and I'm in that central sensitization category where it it made me worse. It would flare me, and I mean, there's so many people out there that resonate with that, and I think it's important to talk about that. Not every treatment works for every single person. So it's
Correct.
important to take an individualized approach, and hopefully doctors are doing that. And it sounds like that's something that you do in your practice.
Well, we do, and we have to, because that's really the only way you can successfully treat a person that has chronic pain of any kind. And I think especially a patient that comes in that has pelvic pain, because I just see that that's one of the most like dismissed population of patients. I think doctors just don't want to deal with it because they don't know, they don't understand. You know, chronic neck pain, you can talk about with your friends. Chronic vagina pain, chronic bladder pain, you're not talking about with your friends necessarily. So you also feel very isolated, socially, maybe, as well as not you, but my patients in general I'm very isolated socially, as well as just like from their own providers that they're trying to open up to, and they just want help.
Yeah, absolutely. And for people who come to you for pelvic pain or pain with sex, and you pick up on the fact that there is like a central sensitization to it, how do you approach that where you don't make the patient feel like, the pain is all in their head? Do you know what I'm asking?
Yes, and I love that you asked it that way, because that is a very common way that patients leave an appointment, making them feel like, oh my God, it's in my head. Like I have to work on my brain. It's just, education is how I approach it. So I go over in detail what central sensitization is, but I also don't want to overwhelm them. So I follow up after appointments an email and a link to a blog that one of my staff members wrote that is very patient-friendly language on what central sensitization is. So I give them like a piece, and then I'm like, I'll follow up with resources so you can read more. But then I also tell them the pain is not in your head. I know you feel pain where you feel pain, but all pain, no matter where it is, whether it's in our low back, our pelvic floor, our heel, our ear, like it's all ultimately processed in our brain. And so this is why why it does often require more of a team approach, a multidisciplinary approach and the word now is interdisciplinary, where you don't just have a lot of providers that are treating you, but with interdisciplinary care, you have multiple providers, but they're all working together. They're all communicating with each other to make sure that they're working towards the same goals. And, I think anyone with chronic pain is not going to find their answer in a single modality. Like surgery is not going to be their answer to get them out of pain. Medication alone isn't going to be their answer. Physical therapy alone is probably not going to be their answer. They usually need at least two providers.
Yeah.
And unfortunately, a lot of my patients, especially that have endometriosis, they have bowel, bladder, and sexual dysfunction. A lot of them, they're seeing me. They have their gynecologist that's probably prepping them for surgery, to excise the endometriosis. They probably have a GI doctor to manage what's happening in their gut. They may have a nutritionist to help with what's happening in their gut. They may be seeing an acupuncturist. I mean, my patients feel like they are full-time patients, but the patients that are able to do that are the ones that will typically do the best if they have the resources to. And I really do wish that healthcare in the US supported patients with chronic pain, but they just don't. Like for physical therapy, they limit visit numbers. They don't reimburse very much. And these patients need one-on-one care. I can't work for an hour and get $17.50 back from Anthem Blue Cross if they even decide to pay me at all. Like it doesn't match. The care they need is not commensurate with what the US health insurance system supports. And it's very unfortunate.
Yeah, absolutely. And you were talking about the interdisciplinary team, and in a perfect world, everyone's practitioners work together. But I think the reality is for so many of us, that isn't the case. And none of our practitioners are communicating with one another. So there's a whole lot of moving pieces that may not all come together at the right time in the right way. Right.
Right. And that's why you have to be an advocate for yourself. Like, don't give up and find that person that will be the quarterback for you. And so I am that person for a lot of patients, if they don't have another provider that's doing that for them. And, I follow up after I do my initial intake. I send my notes to all their doctors and I put on the fax number, my cell phone number, like, please, we still fax. Yes, we do. This is the medical system. They still send faxes. If I put my cell phone number, please contact me directly if you have any questions concerning this patient's plan of care. So I make sure I'm very available. And oftentimes, I'm on the phone 6, 7, sometimes like 8 o'clock at night, chatting with physicians about mutual patients. What are their next steps? Like I'm very fortunate that I have found like a good team here in Los Angeles that all care about their patient. We're not like clock in, clock out job kind of people. We're not like, oh, it's 4:30, done for the day. Like we still work after we're done seeing patients and work to collaborate with these providers. But really it sucks for a lot of the country, I think, because there's just not that type of collaboration happening, but that's truly what's needed for any chronic pain population.
Mm-hmm. Yeah. And it's obvious that you're passionate about this. You go above and beyond for your patients, and that's amazing. I wish there were more practitioners out there that are willing to do that. I think as patients, we do need to advocate for ourselves. And, maybe if a practitioner on your care team is not taking that initiative to go above and beyond, like, what do you think, Heather? Like, can they be like, hey, are you open to communicating with my other, practitioners on my care team? Like, are you open to that? And maybe that would just open the conversation.
Yes, I think that's a very fair question to ask. And I think the response that your provider gives you to that question is also very telling about how seriously they're going to take your care.
Mm-hmm. Yeah.
So I get that asked a lot because I have a lot of people fly in from like out of state or internationally to see me, and they'll say like, oh, would you talk to my physical therapist back home? They just don't have the same level of understanding or experience. And I do, I'm like, yeah, give them my email, connect us on email. And then we'll take it from there. So
Mm-hmm. Yeah.
and sometimes it's a 10-minute call, like just to 10 minutes goes a long way.
Mm-hmm. Yeah, just to touch base. I do the same thing, or at least I offered to, if someone with IC is working with a dietitian, and most dietitians don't really know what to do with people with IC. So it just comes down to like a quick education and maybe sharing some resources, and that could really help to bridge that gap. But I mean, I just think that in these scenarios, if the practitioner isn't responding the way you want them to in these situations, and they're really not willing to go that extra mile for you, like getting a second opinion can be difficult. It can be like doctors or even physical therapists, like there's big wait times to get another appointment. I think that's something we're all going through right now.
Yes. Yeah. And it did really get so much worse during the pandemic. like 5-6 months out until you can see, even a urologist or a gynecologist. Like it's very insane.
Right.
I'm not entirely sure why this is happening. Like I thought maybe locally, maybe a lot of people moved out of Los Angeles. So I do know a few physicians that moved out of LA during the pandemic. So maybe certain areas are feeling that hit a little more than others. But yeah, then it becomes an access to care issue. Like even if you have quote unquote good insurance, you're still waiting months to see a specialist.
Yeah, it's
kind of turning into Canada a little bit. This is Canadian medicine. I think, people up there are used to it. They're used to waiting, we're used to getting what we want when we want.
Yes, we are. I can't believe the wait time for my physical therapist. It's like she's booking 3 months out and I'm like, oh, I can't wait that long. Like, what do I do? Luckily there's like homework you guys can give us for, what we can do at home. So that can help.
Yes, I would hope, but not all PTs are giving a home program. And that baffles me also, because I feel like that's PT 101. Like you got to empower patients to do their own care too.
Yeah, so. I love that word, empower. I just love it. We need more of that happening in the chronic pain community. Okay, so let's dive into, some of these diagnoses more specifically. So can you talk a little bit about vulvodynia and vestibulodynia and, anything else that relates to those conditions?
Absolutely. So vulvodynia just means vulvar pain. So it's like I was talking about before, it's just a descriptor of pain, even though it is a diagnosis. The vulva is our female genitalia. Vestibulodynia is specifically a part of the vulva that is in pain. So the vulvar vestibule is what that's referring to. And that is how I describe it, like the last external structure before you go into the vaginal canal. So the vulvar vestibule, you would spread the outer labia and the inner labia, and it's located on the inner portion of the inner labia. And that is called the vulvar vestibule. So those can be in pain. And so, but what's the origin of their pain? So that takes some investigating. Sometimes it can be hormonally driven. Maybe they have lack of estrogen or testosterone, could be systemic or just local. So typically those patients, if that's a consideration, are given like a topical cream of those hormones to put on the tissue to help like heal or, repair the affected tissue. It could also be due to an overabundance of nerves in the area that become hypersensitive, called neuroproliferation. And that is also something that's explored medically. Secondary to vulvodynia and vestibulodynia, though, I tend to see that patients have vaginismus. So vaginismus would be pelvic floor muscle overactivity of the pelvic floor muscles that surround the vaginal opening, which can create like a closure or constriction of the vaginal canal, resulting in painful sex. Now, that's not always the case. Not everyone with vulvodynia or vestibulodynia has pelvic floor muscle overactivity, but in my professional experience, like 98% of them have pelvic floor muscle overactivity. You can have vaginismus, though, without vulvodynia. So I would say most of my vaginismus only patients don't have vulvar pain. It's just strictly more internal, but they can feel very similar. So they can both be pain with penetration. And if physicians don't know, then like sometimes they're calling the issue vulvodynia, but really the patient has vaginismus, or they're calling it vaginismus, but they really have vulvodynia. And it is important to know because there's different management for them, especially on the medical side. On the physical therapy side, we're still looking at the same things. Like in my office, we don't just look at the pelvic floor. We also do a full orthopedic exam. So we're seeing how posture can affect the position of the pelvic floor as far as its ability to be in a state of rest or unrest, for example. And like, are they gripping their butt, and things that would like also cause or contribute to ongoing pelvic floor muscle overactivity. So, so we want to just consider that there are also things that can be done medically, not just with physical therapy. So with someone that has vaginismus and no vulvar pain, zero vulvar pain, are we going to give them why is the doctor giving them a topical cream of estrogen and testosterone if their vulva doesn't hurt, right? Like, and then if they truly have a lot of pelvic floor muscle overactivity, maybe they need an internal, like an intravaginal suppository that has medication in it to soften the muscles, like a muscle relaxant or like a neurotransmitter inhibitor. So sometimes they have like gabapentin compounded in with a muscle relaxant called baclofen to help soften the muscles locally. So, what population are you going to do that for? Yeah. So you have to be working with the right diagnoses. But they do both result in painful penetration. They both tend to have pelvic floor muscle overactivity. So my treatment approach with them is using medical devices called dilators to help retrain the muscles back to a relaxed state. And it's not like a simple insert and hold. There's still a lot of providers out there that are just having patients insert a dilator and hold it for 10 or 15 minutes. But I take a much more active approach. I think that's the orthopedic PT in me, to try to use orthopedic techniques like trigger point release, different neuromuscular stretches, different massage strokes in the session, and then teaching them with their medical dilators how to replicate those same exercises at home. And those are what I go over in my book as well.
Okay, awesome. So for these conditions, like what can you describe like what it feels like to live with these conditions? Like what should somebody be looking out for?
I think you have the presentation or the, complaint to your doctor that you have painful sex. It hurts with penetration. So vulvodynia and vaginismus are penetrative intercourse conditions. And I should say initial penetration, not deep penetration. And if your doctor says there's nothing wrong, everything looks normal, then your next move is probably to go see a pelvic floor physical therapist, because them saying that, really what they should be saying is there's nothing medically wrong. I don't see an infection. I don't see anything wrong with your tissue. I don't see a cyst, et cetera, et cetera. So, it's probably an issue with your muscles, with how your posture and alignment drives muscle overactivity that needs to be explored as your next step. So I think it's when you feel dismissed by your doctor, if they haven't referred you to pelvic floor physical therapy, and you have an issue in your pelvis, you need to go see a pelvic PT.
Mm-hmm. Yeah. Something I remember as a trigger for me when I was really dealing with vulvodynia, vestibulodynia, and all that was like when I used scented body wash on my vulva, it just burned like crazy.
Right.
And
so there'll be other symptoms like that. You're exactly right. And part of the education that we do is, making sure they're using unscented detergents, and like if they're wearing underwear, if they can tolerate that it's like no synthetic materials in the underwear, that they're not using soaps and scrubbing, and just really being kind to their tissue. So yes, they may have symptoms. You're exactly right. Other than penetrative intercourse symptoms.
Yeah, it could be like contact irritation from your underwear or things like that.
Exactly. And I can tell sometimes if I see someone has a diagnosis of vulvodynia and they come in a skirt, they probably have pain, not just with penetrative intercourse.
Right. You don't want anything touching that area.
You don't want anything touching it. So a lot of them switch to wearing skirts full time. They can't wear tight clothing. So those would be other symptoms as well. Yes.
Yeah. And something that was recommended to me from my doctor for those conditions is the Relivium by Desert Harvest, because it has lidocaine in it.
Yeah, so good. But all it does is mask a symptom. It's not curative, but it can definitely help you with day-to-day irritation until you get to see that appointment that might take you 3 or 4 months to get into. Yeah,
Mhm.
that is that Desert Harvest product I love.
Yeah, it's really great. So what does the treatment like what does your treatment method look like for people with these conditions? Like, do you work on the nervous system aspect of things with them?
Yeah, so there are different down training techniques that we can use. So we do educate the patient on the states of their nervous system. What does it mean to be sort of in like a social zone or upregulated, really downregulated, and what bodily processes are online when we're in various states of the nervous system. So again, that comes back to education, right? Like education is also a form of treatment. You understanding why you have more pain when you're more stressed is very powerful information to have. And how can we support you and making sure you aren't getting to these high stress or really upregulated states as often. A great technique that we'll usually do with patients within the first couple of visits is like looking at their breath pattern, their breathing pattern, and teaching them what I call 3D breathing. So I don't do like a yoga belly breath. I focus more on rib cage expansion to get a lot of diaphragm movement or excursion up and down, because the diaphragm has fascial connections to the pelvic floor. And this is all stuff I educate my patients on, because if I give them a breathing exercise, I want them to understand why. They're not just doing it to improve their breathing, they're doing it to help their nervous system. So as you inhale, your your lungs fill with air, and that drops your diaphragm. And in synergy, your pelvic floor muscle should also drop with that. So you can actually get like passive stretching of your pelvic floor through accessing a good 3D breath. And our pelvic floor muscles are also highly innervated by sympathetic nerves. So what that means in layman's term is innervation just means like nerves that are connected to a particular area. So in this area, we're talking about the pelvic floor. And our sympathetic nerves, our sympathetic nervous system, I should say, is our fight or flight. It's what gets us really upregulated. And since the pelvic floor is so highly innervated by the sympathetic nerves, this is sometimes why our pain is worse, why we also can't poop. Our pelvic floor muscles are tight. We also maybe can't poop because our gut will shut down too if we're really upregulated or in fight or flight, high sympathetic state. Those are all different ways to say the same thing. It's the stuff that happens if your body is under high stress or stress, like if you're being chased by a lion. But it doesn't have to be bad stress. It could be good stress too. You could be like, oh my God, like I got this job offer. I'm going to be up till midnight, like the next 4 weeks, because I got this amazing once in a lifetime opportunity. It could be good stress, but it's still going to affect your body the same way bad stress does. So people also need to understand that it's not just bad stress that will slow your gut, will make your pelvic floor muscles overactive. We all need to just kind of do a self-assessment and see what state are we living in. And we shouldn't always be in rest and digest. We should know, it's good to be upregulated sometimes, but we can't live in that state, and we need to be able to come down. Breath work is a great way to access that for those reasons.
Mm-hmm. Yeah, perfect. I completely agree with everything you just said. Before we wrap this up, do you have anything else you wanted to say about these conditions or anything related to what we've talked about?
Yeah, I think just touching on the point of like overlapping pain conditions that you mentioned at the very beginning. So it is very common for vulvodynia, painful bladder syndrome, and endometriosis to cluster together. Like in the medical community, we call them the evil triplets. So if someone has one, you should really at least be open to exploring, do they have all three? And maybe they don't, like they don't 100% of the time, they don't have to live together, but way more often than not, they do. So those things should be explored. And we didn't talk much about endometriosis, but from a sexual standpoint, that tends to present more in deep penetrative intercourse. So like patients will have pain. They'll say it feels like my partner or the vibrator or whatever they're using is hitting my cervix, and it's very painful. With endometriosis, it's an inflammatory condition, and it creates scar tissue inside the body, which can affect bodily internal bodily functions. Like it can affect fertility if you have endometriosis on your ovary or around your fallopian tubes. If you have it on your bladder, there's something on your bladder that's inflamed on a cyclical basis. It can be on your bowels. And when all these things turn to scar tissue, like it can even constrict your bowels. And so endometriosis should always be something that's explored. And just to define that, because there is still, I see people putting misinformation on the, social media and everything on what endometriosis is. It is not a condition of the uterus. So for example, a hysterectomy does not cure endometriosis. Only the sort of like a laparoscopic outside the uterus type surgery that's removing or excising the endometriosis is what is recommended for, removing or curing that part of the disease. But you still have to manage all the secondary things like the central sensitization, the pelvic floor muscle overactivity, the postural dysfunction, on and on. But the reason why it hurts so much, why even doctors get confused. There's been so many theories over the years as to why, or as to what endometriosis is from like a cellular standpoint. And even like one old theory, which is not true, but I even had a patient and she is from a foreign country, but this happened on Monday. When I asked her if she knew what endometriosis was, she's like, yeah, it's when you have your period and some of the blood leaks out and it goes around your other organs. And I'm like, well, not exactly. Endometriosis is already outside of the uterus, and it just responds the same way the lining of your uterus does. So it bleeds, but there's nowhere for it to go like it does during your period. So it just kind of bleeds, gets inflamed and turns into scar tissue, but it's outside of the uterus. It's similar to the tissue in the uterus, but it's not the same. And it's not coming from the uterus. It's not leaking out. So there still are a lot of people that believe that and think that. And I just think it's an important thing to note from like a management perspective, because there's a lot of young girls having hysterectomies because they think that will cure their pain, and it won't. That's not a cure for it. So, you can have endometriosis of the uterus. That's called adenomyosis. So a hysterectomy would cure that, but it doesn't cure endometriosis.
Okay, got it. Now, I know you have patients to get to, but can you tell everyone where they can find your book?
Yeah, so I have it on Amazon and on soulsource.com, which SoulSource is a USA designed and manufactured dilator company. And so, those of you listening like to support US, but you can get my book and dilators on that website. I also, if you wanted it like yesterday and you can't wait for Amazon, I have it on PDF at sexwithoutpainbook.com. And I give you a code for that for your listeners, Callie 20 for 20% off the PDF. So that's also accessible 24/7. So you can have it, in minutes.
Awesome. Well, thank you so much for your time. And I'm looking forward to just keeping in touch with you on social media and seeing, all the amazing things that you're doing.
Oh, absolutely. Thank you for having me on, Callie. This was great.
Of course. I always can.